Hey everybody, and welcome back to the latest episode of Code Brew. I'm Joe King, and I'm here with my co-host, Lukewarm.
Hey everybody.
And we are back. It's episode 7. We survived the snowpocalypse, and we are, well, maybe not too much worse for wear. Excited to be here, and today we're focused on stroke. So I think we really want to talk about the complexities of a stroke and how they can mimic other things, numerous other things. And we've talked about on other episodes, especially the past 2 episodes, about some altered mental status and stuff. But we really want to focus on stroke, and we do have some data for Get With the Guidelines to talk about inpatient stroke and also just a stroke from the ER standpoint too. So we have a lot to go over. And we're excited. You know, this is something we do definitely every day as rapid response nurses. You know, we're gonna talk about hepatic encephalopathy at the end or after we talk about stroke, just because they seem to be so similar, and then also just because that's something we see frequently, especially here at our hospital where we have a lot of stroke care. We have a specialty in that, and then also we do have a lot of liver patients. So I had to reference our title really quick, Blurred Lines. I don't know if anybody's noticed, but I've started with a theme of song titles for our different episodes.
I'm not sure I noticed that either.
Yeah, I didn't ask anybody. I didn't ask you. I just was like, this sounds cool. So Blurred Lines, obviously,
Not do I know this song?
Blurred Lines, yeah, you do. You know Blurred Lines. I'm not singing it because I don't have that kind of talent. But, a reference to 2 things. First of all, blurred vision is something that can be a sign of a stroke. And also, blurred lines between, stroke and other conditions that mimic it. So,
You're so witty.
I am. I'm so witty. I feel very witty. Anyway, before we dig in any further, we do have our disclaimer I want to go over really quick, as always. So,
oh gosh, it's by Robin Thicke.
It is Robin Thicke.
For real?
Yeah, it's a great song.
Okay.
It's a super great.
Sure, go ahead.
We'll listen to it later, but not on the podcast. We're not playing any copyrighted content. So, disclaimer: the views and opinions expressed on Code Brew are solely our own and do not represent the views of our employers, professional organizations, or any personal or professional affiliates. This podcast is for educational and entertainment purposes only and should not be considered medical advice. You got that? Is it clear?
Heard.
All right.
I don't think I said it cool enough.
You don't say anything.
Heard. I texted. It sounds cool in my head.
You never say anything cool. It's like something you're not capable
of. I've heard that before.
I just want to make sure that's clear. So, okay, stroke basics. Luke, what is a stroke? For 600.
For 600 points. $600. Okay, so what? Like ischemic and hemorrhagic? Is that
right? Let's break it down. That's a good place to start. So we have the ischemic related, the ischemic stroke, which is related to a clot, right? It's a blockage. Things are stopped.
So we have like a thrombus in the brain.
Right.
You have like maybe a cardioembolic event where clots dislodge from the heart. And traveled until it can't travel anymore, and then it stops. It's disrupting blood flow distal to wherever it's landed. Right?
Yeah, that's it. Yeah.
Do I get the 600 points? Points? When you say 600?
I think it's dollars.
Okay, fair. So,
but I'm not giving you $600. So we're clear.
The game's not as fun.
Yeah.
And then there's bleeding. So bleeding
right.
could be a rupture.
Right.
So there's AVM. So there's some weird blood vessels that could happen. There's aneurysms. There's weakened blood vessels. And I think a lot of that rupture is just going to have to do with hypertension.
Right. A lot of that has to do with hypertension. You can have some congenital issues. People are sometimes born with aneurysms. Sometimes they run in families. But that's a weakening of a vessel. And, even then, sometimes it's usually related to, an increased ICP from, high blood pressure or some kind of event. But yeah, clot versus bleeding is really what we're looking at. Or,
also, you do hear about like 2 more categories. So you hear like the TIA and that's like the trans ischemic attack. and kind of think like, well, that's a lottery of strokes, but that actually just kind of means that like although the symptoms are going to resolve in less than 24 hours, you're probably going to have a stroke in that.
Right. It's a big flashing sign that says, it's a red flag.
And then like when I was studying because I think it was PCCN, and they were like, no, it was CCRN. And it was like RIND.
RIND, okay.
Like, that's like, it's reversible, but greater than 24.
Oh, okay. Yeah, okay.
So, I don't know. One thing about stroke that's always like kind of like stuck on my mind is, I was at a class sometime, or I don't know, but somebody verbalized like the goal of stroke therapy is to minimize disability. It was like the saddest sentence that I've ever heard, because we think, oh, we can cure this, or we can do this. We have so much modern medicine and technology. When you're thinking about like minimizing disability, it's like, it's not really getting rid of anything.
I mean, that's a very, it's eye-opening. I mean, it really puts things in perspective. Like, we're trying to hope that they don't get any worse, and maybe try as best we can to dial things back so that they can get back to their normal life. And then, skipping ahead, but since you brought this up, the other thing to remember is time is brain. And we're moving quickly because, every moment you're essentially, possibly losing more brain, functional brain. So every second counts to preserve brain function. And we're going to go into all these like time critical metrics that fall into the get with the guidelines stuff. Yeah, you're minimizing disabilities. I do want to focus on the BEFAST acronym, because I feel like, number one, I mean, this is like, there's a lot of info out about this. I mean, this helps with your patient education, but I think it helps with our new people, and like just something for you to remember as far as like how to assess a patient really quickly and say, oh, I might need to call some help on this.
It's a magnet on my fridge at home.
Oh, because you're such a nerd.
What I'm a nerd. I mean, everybody needs a magnet.
Everybody needs a magnet.
All right. So what is BEFAST? BEFAST. That's what you're saying.
So okay, B stands for balance, right? So if they're we're baseline not having any balance issues, we're not dizzy, and suddenly they're having balance issues, and
balance, impaired gait.
Yes, impaired gait. I mean, dizziness also falls under this. So, like vertigo type symptoms, if you're having a balance issue, that's definitely something to look at. E stands for eye changes or vision loss. So, that ties back into our title, blurred lines, blurred vision. There it is. So, F stands for facial droop or facial asymmetry, as we might see in our charting. But when you're educating your patients, facial droop really helps them understand. And droop doesn't just mean our mouth. I mean, I think that's something we do need to touch on, is that you can see it like in an eyebrow, you can see it in the nasolabial folds and that kind of thing. So, we fall back to the mouth droop, but there's other things that can droop as well on the face. So A stands for arm weakness or numbness. So arm for sure. And then S is for speech difficulties or slurred speech or sudden inability to speak. So it could be like word salad. It could be you show them a pen and they can't say pen. They call it a phone, they call it a dog, they can't find the word or something like that. And then a T just stands for time to call 911. Or if we are in the hospital, that's your time to activate the stroke team, page out a code stroke. So
BEFAST. So it's balance, eyes, vision, facial drooping within the face, arm weakness, speech difficulties, and then time, because we're time is super important, because 2 million neurons are compromised every single minute that we delay stroke treatment.
Is that really the number? Or just make that?
It's like 1.9 million.
1.9 million? Golly, that's crazy. That sounds like a lot. I mean, some of us don't have any neurons to spare.
That's a weird look that you're giving me right now.
This is why we don't have a video podcast. So
smile for me, raise your eyebrow.
And we'll go.
Why do we do that? So that's why we do that quick assessment, right? Like,
smile, show me your teeth, raise your eyebrows, puff out your cheeks.
Yeah. So my plug for this would be like, I always say you need to do bedside shift report.
Oh, yeah.
We need to notice these things. You've got patients and it's like, gosh, I work night shifts and I'm kind of waking up at midnight. I'm going to wake them up at 4 a.m. to do assessments on them, and they're going to be discharged tomorrow. Like, why do they still need this? If I don't wake them up at 4 a.m., I don't get a good assessment on them, and at 8 a.m. there's some type of deficit that's making the oncoming nurse think that potentially they've had a stroke. I can't say that I did a good assessment on them at 4 a.m. Their last known well might be midnight. Like that's the last time that I can actually speak to them not slurring or having a strong grip. And that's going to rule them out for treatment.
Right.
So their last known well is going to be greater than like the 4.5 hours.
Right. That's a good point, and we're going to touch on those things shortly when we get to the guidelines. But I'm
always going to say at a bedside round, I'm always going to say we need to be assessing those things, and sometimes as uncomfortable as it is to continually wake people up, and you hear the patient, I just honestly educating on the importance of why it is that you're doing those things, doing this assessment.
And this is not just your neuro patients. This is pretty much all your patients. I mean, everybody in the hospital is at risk for a stroke. They're laying in the bed, and we talk about like DVT prophylaxis and all this stuff. Like, we try to get people moving, but like because of the fact that they're laying in the bed, they're at higher risk for.
And no matter how much you're moving in the hospital, I mean, like, even when you see a patient like ambulating in the hallway 3 or 4 times a day, you're like, wow, they're doing great. I mean, that's a total of 20 minutes maybe.
Right.
So like,
it's not enough.
The rest of the time that would be like me being on the couch for 23 hours and 40 minutes.
Right.
Watching Netflix, which I'm not going to say I haven't done.
Yes.
But and that's a pretty mobile patient.
That is a pretty mobile patient.
If they're out,
they're
ambulating 5, 6.
They're in the hospital, everybody needs like some form of neuro assessment. As frequently, every 4 hours, I think, is like probably the minimum.
It sounds like, so I know that you said that you want to compare this to like hepatic encephalopathy and yeah, so like the liver patient and like, what that buildup of ammonia looks like, especially with like impaired neurological status or compromised neurological status. But, also hypercapnia.
Oh, yeah.
So decreased level of consciousness, hypoglycemia, because we're always going to say in responding, what's their blood sugar?
Right. We always want that.
It's going to be the first question. So what's their blood sugar and what's their last known well? There will be other questions, but those are the ones that are really important, because if their blood sugar is 28, hypoglycemia mimics stroke. Let's fix
100%. Yeah. And that's something, I have a little bit further, in our episode outline, but you're right. The first question we're going to ask is, what is the blood glucose? And if you're a nurse and you're taking care of a patient in the hospital, you call a code stroke. Like, I want you, the first thing you think after you call a code stroke is, I got to get a blood glucose, because they're going to want it as soon as they walk in the door. Like, if you already have it, you get a gold star from me, You'll never get a gold star from me. I know you want a gold star.
And I have a gold star.
Yeah, you're never going to get a gold star. I'm going to withhold it from you just on purpose. So
I literally just said that this is what we do.
I know, right?
Okay.
No. I love this analogy, so I wanted to talk about this just for you to think about. So, like, think of your brain like your favorite playlist, and you've got 100, 150 songs. So, like, every minute without blood flow in your brain means you're losing another song. So, I think it's a cool analogy. I don't know.
Yeah.
Do you like it? You feel it?
I like it. Yeah, I wonder if I could relate it to something else.
No, probably not.
Okay, so what's time?
Let's get with the guidelines.
What's time 0?
Time 0? Time 0 is last known well. Last known normal. The last time you saw them at their baseline level of function.
Okay.
So we need to talk about, get with the guidelines. Who started this, or who are we talking about as far as guidelines? And these are metrics that we know through research have shown that they improve outcomes. So if we stay within the guidelines, and this is from a joint venture by the American Heart Association and the American Stroke Association. So if we meet these target times, we've improved the patient's chance of a better outcome. So we consider this the standard of care. So that's where we're getting this from. And it's well documented, I think. They put a lot of work into this. So it definitely helps us know where we're succeeding, where we're truly helping our patients. So like Luke said, time 0 is the last known normal. If you've seen your patient 30 minutes ago and you were able to have a normal conversation about what you had for lunch and where the patient lives and what they did for a living, and then you come in 30 minutes later and, your patient can't tell you what day it is, what month it is, has like a strange like droop on the side of their mouth, and they can't lift their left arm, then your last known normal, you're 30 minutes ago. So that's where we're looking at. So, I mean, I'm trying to make this as simple as I can, because I do think the last known normal is something that people get a little confused about. But that's something we want to know. I mean, that's after we ask for a blood sugar, last known normal is going to be the next thing we ask, because that helps us decide what is this patient a candidate for as far as treatment plans. So then the next time target, we want this patient. So you assess this patient, and we'll go over, some assessments moving forward about like NIH and different types of neuro assessments. But the next thing we want to make sure, the next target to hit is you're going to activate the stroke team, and that starts a clock. So you activate that stroke team, you found this patient at this time, and we want that patient to see a physician within 10 minutes. We want them to be evaluated by a physician within 10 minutes, a stroke certified physician. So, I mean, typically that's going to be a neurologist. Now, it doesn't always have to be a physician. Like some places, like here where we are, we have a stroke NP. She's a specialized NP, and she's excellent. And, that definitely, meets the guideline. So
door to provider.
I mean, 10 minutes is max, right? So we definitely, the sooner the better, but definitely no longer than 10 minutes. So another thing we want is when you find this patient and you've noticed that they are not having, their symptoms, look like a stroke, you're questioning what's happening. The next thing is we want you activating the stroke team within 15 minutes. I think 15 minutes is pretty generous, but if you're not really sure, if you want to, you're double checking, you're reassessing, you call your friend over and, hey, look at this. I mean, 15 minutes, I hope, is the maximum time it takes you to call the stroke team, especially if you're in hospital. So when we use the term door, I guess I probably need to clarify this. Door is whenever you've identified symptoms. So if you're looking at an ER patient, then they do use the time they hit the door, the time they arrived in the ED. But if you're looking at an inpatient, it's the identification of symptoms is considered your door time.
Yeah, I think that probably could be really confusing.
Yeah, I do see it.
You're like, how's that spelled? Door.
No.
Yeah.
Yeah. So, and I have that ED in mind. So I think about it as door is like what time they hit the door. But if you're in hospital, you do have to look at things a little bit different.
So we need to get this patient
to the scanner.
The scanner.
CT scan. Yes.
25 minutes.
Within 25 minutes. They need to be on the table. They need to be getting scanned.
So what does that look like for the primary nurse? So let's say we're in a hospital that functions with a rapid response team, and, they're going to travel with this patient. The primary nurse, so they need a blood sugar, and they need to know a last known well, and they're coordinating and calling the stroke team and all that kind of stuff. We really need to get that patient prepared to travel.
Right. For sure. And for some patients, that can be a lot. I mean, if you're talking about a patient on a ventilator, you're talking about, I got to call RT. I got to get an oxygen tank. And there's a lot of things I got to get together.
Hospitals are big, and CT machines are very expensive. So they're not floor.
Very true.
So, getting, a patient from the 12th floor of a facility, to the emergency department or wherever the CT is located,
right,
that can take time. So really important to know, get the bed.
That's a good point.
Elevated and moved and get the portable oxygen.
Like untangle the phone cord, untangle the bed alarm cord, or what have you. Think about these things. Like, how do I get this patient out of this room, down the hall, down the elevator, or what have you, whatever your path is. from our standpoint here at our facility as a stroke team, as a rapid response nurse, part of my responsibility is, number one, escalating that or, initiating that move and doing that transport and make sure the patient's safe. But also we actually do the transport ourselves and we move quickly. So when we get there, like, we're not being rude. We're just like, hey, we got to roll. So
what if you get there and the provider is going through like a full NIH stroke skull with a patient?
You're like, hey, you can do this on the way, like in the elevator.
We can do it on the way. We can do it after the scan.
You can. I mean, because a full NIH is not the first priority.
It is completely appropriate.
The scan
to let them know we're going to travel. You can do this when we pull them out of the machine.
100%.
There are questions that you can ask on the way to make your assessment.
So we frequently do NIH in the elevator. Sometimes we do them on the way down long hallways. No, 100%.
Well, I think, sometimes like nurses don't want to question providers. It's like, this is the neurologist. The neurologist is going through that checklist as well in their head. They're like, oh, I need to get this, what's their deficit, their level of deficit, and have an understanding, is this real, but, I think.
Don't be scared.
For the sake of time.
Yes. Don't be scared. You're doing what's right for the patient. I do want to clarify, though, one thing. So it is the CT head without contrast that we're trying to get done the most quickly. You may see us, and we do perfusion scans. We do CTAs of the head and neck. I mean, there's different scans that we do. But for the purpose of Get With the Guidelines, we are trying to get the CT head without contrast done as quickly as possible. Some patients, we don't do CTAs. Sometimes we don't do CTPs. For us, like, that is our priority. So we don't necessarily stop for like IV access or anything like that.
So why the CT?
Why the CT?
Yeah.
Oh, what are we doing? Why are you asking me? Oh, asking yeah. So we're trying to make sure they don't have a bleed.
Okay, so we're just trying to roll out a bleed and a CT's quick.
Yeah.
Okay. So it's gonna.
And why are we ruling out the bleed? Pass it back to you.
Bleed, because if it's not a bleed, then it's probably an ischemic event.
Right.
And then we're gonna see if they qualify for fibrinolytic therapy.
Yeah, your TPA or your T in case.
Yeah.
Yeah, that's it. We're going to try it.
Just Googled it.
You just Googled it? No, you didn't.
Yeah, so
no.
So we're doing the CT. It's quick.
Yeah.
MRIs take a long time. Yes, they had a stroke, or yes, there's a deficit. Probably going to follow up and we're going to look at that brain in more detail.
Yes.
But when we're talking about, every second, every minute, time is brain. We really need to know what therapies we're gonna drive here. And we're able to make a quick decision with a CT, which is, a pretty fast diagnostic.
Yeah, very quick.
It's gonna tell me they have a bleed or they don't have a bleed. And if they don't have a bleed, are they a candidate? So I'm going to start going through that checklist and are they a candidate for a clot buster? So something that's going to break up that clot and then restore distal perfusion to the...
So a couple other target times for our Get With the Guidelines that I want to touch on. We do, and a lot of times, I mean, this is completely, as far as this goes, it's completely out of the hands of nursing staff. But one thing I do want you to know, we do want the CT interpreted by the radiologist in less than 45 minutes from the time that the patient's symptoms were identified or they hit the door. So that's something more of a facility thing. It's definitely a physician thing because our radiologists are physicians. But most of the time, I think the biggest thing for make sure whenever you put your orders in for your CT head, if it is a nurse-driven protocol for a code stroke, make sure you put them in a stat or even identify them as a code stroke. Some order sets are identifying them as a code stroke because it's even faster than the stat CTs, right? So, and the last thing, very important, door to needle time or identification of symptoms to needle time. And needle time in this case means your IV thrombolytics. So we want to try to get those things started in 60 minutes or less. The quicker, the better. So, and those two main ones that we think about at this time are your TPA or your alteplase, and then your T in case is another option, and the tenecteplase. That's what the other name for it is, tenecteplase. So we, as a facility, have gone away from TPA for stroke care. In most cases, we have transitioned to T in case in the last few months, and we're excited about that because it is a little bit easier. It has less room for error. And but a lot of facilities are still using the TPA or the alteplase. So both still meet the guidelines at this time. So moving on from time targets. I mean, I think the biggest takeaways from the Get With the Guidelines for us as nurses to remember is early stroke team activation. And if you're working in the ED, a lot of times that means your EMS is calling and saying, we think we have a stroke. And that's great. That's excellent.
Well, they're even looking at symptoms to see if it's like a large vessel occlusion,
right?
You know, and actually targeting centers that they go to,
right?
Specific hospitals that can actually throw them back to me, like a
comprehensive stroke center is like, you know,
primary or secondary, correct?
Right. And that's like, you know, different types of treatment options. So making sure that you go to a place that has all the treatment options if available. So the other two takeaways, we want early imaging and diagnostics, and then we want reperfusion therapy as quickly as we can. And the two options for reperfusion therapy, one we've already talked about, your thrombolytics, your TPA or TNCase. The other is a thrombectomy. It's an IR procedure where they go in and just pull that clot out. It's obviously way more complicated than that.
Yeah, it sounds so easy.
Oh, I'm sure it is. They just easy. They just pull it out.
I was like, yeah, I like it.
Yeah, but it's, you know, that's definitely not my specialty, and I'm excited that we have this kind of thing available for our patients. But it's another option. So our patients that have that large vessel occlusion that we've identified through the CTA or the CTP, the perfusion study, they may be a candidate for a thrombectomy.
So we've really given like a lot of times here, but as a bedside nurse, so great, we've got a journal review, but as a bedside nurse, bedside shift report based assessments.
Yeah.
You know, if I have a stroke patient doing NIHS handoff.
Oh yeah.
We can talk about that later. You know,
to see how to change,
understanding what weakness is.
Yeah.
Somebody might say weakness, and your version of weakness and their version of weakness are a little bit different. Right. Getting that blood sugar, getting that patient ready to go, calling the acute stroke line. So that's really what we need on the front end to set the patient up for success. You know, if you're not working in the ICU, those patients probably, they qualify for some type of reperfusion therapy. Probably not coming back to you, but you know, that is what we need on the front end. That's staff.
So, and then from a facility standpoint, we are hoping that stroke team notification is like a single call. We're hoping it doesn't have, you know, multiple steps, because you know, whether it's like a paging system or a text system or a page overhead in the hospital, whatever the case may be, we are hoping that it only takes a single call to activate it for the nursing staff. And then we do want, especially for an ED or, you know, from a nursing standpoint, getting that rapid neurological evaluation, we should get it done as soon as possible, whether they're in the ED or maybe we wait till they're on the CT table, and we can do that. That's those things. And you can step in, like we say, you can step in and say, hey, the CT is more important.
We're not going to delay the CT.
Yeah, we're not going to delay the CT for really anything unless the patient's just medically unstable, right? So we talked about the glucose. You know, I think it is important. We talked about BEFAST. I think it's really important. We don't talk enough about educating patients, maybe, but I think that's very important that we talk to our families about, patient families and our patients, just to know the signs of a stroke. So if once they leave us, we've given them a tool in their toolkit to identify if they have further complications, right?
I would say most hospitals, I know we do, that is just a standard part of any discharge.
I hope so, yeah.
So that is written on every discharge instruction. And so when you print it out, you know, it's a standard paperwork that you're giving the family or the patient. And I think it's really important to hit that. So while we might not think it's relevant to their stay, because somebody that came in with a stubbed toe is probably going to get that as well, it is going to save lives.
It is going to save lives, for sure. And then also, like, whenever you're doing your discharge, or anytime you're educating your patients, talking about things like if they're on anticoagulants, like how this could be the one pill in their inventory, in their options that prevents a stroke. I mean, you can use that kind of things to help ensure patient compliance going forward. Like, hey, we give you this pill so that maybe you won't have a stroke. I know that's so overly simplified, but these are things that people would want to know. So Anyway, so moving forward, so if we're looking at, so we've talked about stroke and different things, we want to look about things that mimic. We've kind of focused on this episode as hepatic encephalopathy, but we've talked previously about different things that also mimic stroke. We talked about your hypercapnia, your high CO2 levels. We've talked about, like Luke was saying, about the glucose
toxins, drugs.
Toxins. There's a million things.
Buildup of ammonia. So
right.
All of those things that we, like when you first encounter a patient, it seems like they are confused or have a diminished level of consciousness to where we think that they should be, or where we were told that they were. What we're looking at
look exactly like a stroke. It doesn't. I mean, a lot of times we do a code stroke, we do the whole full workup on a patient because we're concerned about it, and we can almost see, even before we get a CT scan, that we probably...
I think the confusion comes, I always get scared, like when I'm charting or something, or when I'm looking at a patient peripherally, in their chart, let's say we've got a Muse alert, and I'm like, hold on, they were GCS 15 earlier, and now they're confused,
right.
or whatever. They were completely alert, oriented, cooperative, whatever. And then now all of a sudden the next assessment is they're confused, that
right.
That scares me.
It does scare me, yeah. As it should.
I'm like, hold on. So what was this?
Something's different.
When they're like, oh, it's just sundowners or whatever. When you talk to the nurse.
Could be several different things.
You need to ask those questions,
right.
Verify, and be really good at your, assessment, and not just assume. I was doing an assessment one time, and I'm talking to this guy, and he's talking to me about. He was talking about physics. I don't know. It was we were having this.
He was way over your head, clearly.
For sure. I don't know what we were talking about. Yeah.
Yeah.
Literally, I don't know what we were talking about. But it was all of this crazy stuff. Obviously super intelligent. And I think I was getting ready to walk out of the room. Didn't ask him the orientation questions, realized that I just thought oh my gosh, he's so alert. We're talking about modern events and whatever. And then he was but those aliens, I don't remember exactly what he said. And I was like, oh, he's not with it, but the importance of orientation questions, and the importance of, not just the assumption that because somebody can hold a conversation, whatever, hold my interest.
Right.
You're looking at me weird, but it was a conversation that seemed up to date and current.
For sure.
And then as I was about to leave, I'm like, learn oriented times 4, he started talking about something so off the wall, and I was like, well, okay. Need to make sure that I always ask those questions. Really important,
And so what are those orientation questions? We actually haven't touched on that. So what are those? What does it look like for you or for everybody? What it should look like?
Person, place, time, and event.
Yes. Where are you? Who are you? What year or month? Some people don't know what year it is, and you can't really count off because, but...
So, when the year switches...
Yeah. It's still January.
I switched to 2025, and
So if they say 2024, I don't really count off for that. You're pretty close. I'm gonna correct you, but I'm also not gonna count off.
Well, it takes me till about July to get it right. I think that people have actually told me 2025, and I'm like, almost.
Yeah. Yeah.
And then I'm like, oh no, you're right.
No, I think we asked their name, we asked, where they are, currently. So they say such and such hospital. And you have to consider though, if they know they're in a hospital, that usually is enough for me to count. Okay, you're good to go, because sometimes people don't know where they ended up. You get transferred or you brought in by EMS, and they're, especially if they're in the ED and they just got there, they're really not sure. They definitely can be not sure where they ended up. Okay. And then why I came in, which is, my liver's bad, or, it may be a very, quick generalization, but those things are important. So let's look at hepatic encephalopathy. So first of all, if I say encephalopathy wrong, please forgive me, because it's kind of a tongue twister.
Being that you're from Mississippi, or
being that I speak fluent cornbread and switch in and out of it in regular English, yes, that's what I'm talking about. So I do sometimes have trouble with this. No, altered mental status, generally it's caused by liver dysfunction and buildup of toxins, particularly ammonia. We are looking at ammonia level in particular for this one.
If we're thinking about the liver, like,
Yes. You can have
anticoagulation, albumin production, filtering out toxins in the body.
It's definitely
filtering that.
Yeah, it does all the things.
And then filtering ammonia.
Right.
Yeah.
And I mean, just to be clear, you can have other forms of encephalopathy. So, and metabolic encephalopathy, it can, you can call it that, and it may be other toxins. You might not be looking at ammonia, and it can sometimes mimic stroke as well. I don't want to get you overly confused about talking about these other types of encephalopathy, but just know that there are other kinds. But for the sake of this conversation, we're kind of focusing on the liver because it really presents itself similarly to a stroke. It's not exactly the same, but it can be confusing. So as far as hepatic encephalopathy, the main symptoms would be confusion, slurred speech, and motor impairment.
I feel like with this motor impairment, though, it's like
it's more generalized.
So like the person is like more shaky.
Yes.
And weak.
Yeah, like slow.
But it's like
grab things or like almost like moving through jello.
Yeah, fair. Rather than, stroke is like I like literally can't move one part of my body.
Yeah, like I used to be able to
very
myself
impaired,
and now my left arm
on a single side of my body.
Yeah.
Where this is that like hepatic encephalopathy, that sloth like.
Yeah, sloth like. Ooh, I like that.
Yeah, I think like the moving through jello, like I get it.
Yeah.
But yeah, like it is like the sloth like movement. That show was where they're at like the DMV. I'm like seeing the sloths who are running the DMV.
Oh yeah.
Utopia, I think.
Yeah.
That is how I imagine the DMV, or that is how I feel. But anyway, so they're slow, they're shaky, the cup is kind of shaking when you hand them, their medicine.
Speech is slow.
Speech is slow, but you're not having that like unilateral.
Right. And that's one of the key differences. And we're going to break these things down just like that. I mean,
medicines this patient normally getting, or what should they be getting?
We're always gonna be looking at medicines.
So they should have an ammonia level at some point. But this patient, so the liver's not functioning process. Ammonia is going to build up. That's going to be like a poison in their body that's causing this hepatic encephalopathy. And we, since the liver can't get it out, we're going to give you lactulose.
Right.
Lactulose is going to pull it into your gut, cause you to have bowel movements.
Yep.
And we're going to titrate up to
be everywhere.
2, 3, 4 bowel movements a day.
Right.
And while these aren't people's favorite bowel movements, we need to make sure that they're getting this medicine.
Yeah.
We don't want to
skip lactulose.
We want to make sure that they're getting it.
Yeah. We don't like for people to refuse lactulose. Like if they're a liver patient, they need to be getting their lactulose. So, we really want to push it. Yeah. So, I mean, the similar symptoms are just the fact that they are altered. They do have motor weakness and they do have speech changes. But like Luke is saying, so a stroke in contrast, a stroke versus the hepatic encephalopathy. So on the stroke side, it's going to be sudden. It's really going to start very suddenly. They're going to be fine, and you go in 10 minutes later, 20 minutes later, and there's something significantly different. On the encephalopathy side, it's gradual. Like as that ammonia increases, as those toxins increase in the bloodstream, you're going to see the symptoms progress, right? So on the stroke side, the deficits that you see of neurological deficits are going to be focal. So, or unilateral. So like one side of their face, one side of their arm, one side of their legs, and then for encephalopathy, we're looking at, they're bilateral, generalized weakness. So we are going to talk about, we're going to talk about the history. Do they have a history of liver disease? Do they have a history of elevated ammonia? But we have to remember, stroke patients can develop liver disease, and liver patients can have a stroke. So there can be some overlap. Right. They're not mutually exclusive. So that's when you really have to kind of figure out, what are we dealing with here? And at the end of the day, I'm always going to say, I'd rather you call a code stroke and it not be than you not call it and it is. So if you're suspecting it, but you're not really sure, just pull the trigger on it and we'll find out. We'll scan them. We'll look at everything and we'll figure it out, right? So the things that we need to differentiate between the two, we need that CT. We may progress with an MRI. And most of our stroke patients, unless they have a contraindication, are probably going to end up getting an MRI, maybe 2, maybe more. And then blood work, we're going to look for that ammonia. We're going to draw one. It's not something you can get like super fast. You're not going to, have it. It's not like a glucose or anything, but we can get it back usually within a couple hours, and we'll see what we're dealing with there. Okay, so moving forward, how do we manage these two things? So as far as stroke management, if you suspect a stroke, activate your stroke team. We're going to do the quick assessment. We're going to...
Yeah, so even if we know, like, the NIH stroke scale, we're not going to, like, immediately implement that. That's a really long...
Oh, yes. Yeah, and you have to have the certification. We have to update that certification every year.
The FAST screening tool,
yeah.
And then we switch to this BEFAST screening tool.
Mm-hmm.
So you want that quick general assessment.
Yeah.
That's going to tell me a lot.
I have enough red flags that I want to get a scan.
We're gonna drive some care based on my presentation.
And then if we've ruled out we've ruled a head bleed on our scan.
Can we administer TPA?
Are they a candidate? So I mean,
big lung screening tool. We can work on that. Provider will fill it out. Contraindications are going to be like recent
surgery,
brain bleed.
Recent brain bleed. Yeah.
Current brain bleed.
Yeah.
Elevated INR, like, I don't know, it's like greater than 1/7 or something.
I mean, there are a lot of contraindications.
And this stuff changes, it changes kind of like stuff that used to be like completely contraindicated as like, relative contraindications. So, you're always looking at like risk benefit here,
right?
So that is a list that the neurologist will be going over with.
It's not a nurse decision, and we're there to facilitate. We're there to if you've been trained on your TPA or your T in case, you'll know if you've been through the training for that. So this is one of those...
Great to expect it.
Yeah.
To know that it would be for an ischemic stroke. I'm great to know why we're doing the CT, but maybe just because we're always in the window doesn't mean we're always going to get it.
Right. So for most nurses, the big thing is going to be knowing when to initiate it and making sure you're doing those ongoing assessments, right? One of the things I love about, and this is the TPA, the T in case part is one of the times when I really love to have my pharmacy friends available because they
they're good.
They're so smart and they spit out their contraindications and they'll mix it for you and it's like
calculating and stuff that went with Alteplase, how they would.
I know.
I was a fan.
I get super spoiled by our pharmacists for sure. But yeah, so so what if we've ruled out a stroke? And what if we're thinking it's the hepatic encephalopathy? Like we said, the lactulose is the main thing. There is another drug called rifaximin that they use to treat a liver disease. So you might see that.
When I see this big old pill, I'm just like,
it is
actually everything about this patient. I don't know. Like whenever I see it, it's so interesting. So the about like this medicine kind of like a detail, like so our body is like, we have these bacteria that are like releasing ammonia.
Right. And they're good bacteria. They're supposed to be there.
And this gets rid of that. So it gets rid of that extra ammonia production that the liver can't function. It's a giant pill. But whenever I see it, I'm like, I know what's going on today.
Yeah.
When's the lactose? How many vitamins?
Oh, yeah.
Is the patient yellow? Like,
and that is the primary complaint about the Xifaxan, the rifaximin, is it's a huge pill. But yeah, and then supportive care. I mean, obviously, someone who's in liver failure, whose ammonia is elevated, we can treat the symptoms, and we usually a lot of times can't cure the cause. So those patients are usually pretty medically fragile. So just remember that too.
Understanding that in and out of confusion.
Yeah.
Based on how we're able to reduce that ammonia level,
right?
But the patient safety is a big factor.
Very true.
Just because they used the call light and called out to go to the restroom at 6:00 in the morning doesn't necessarily mean that they're going to be that way at 4:00 in the afternoon.
100%. Yeah. So, I mean, making sure we keep them safe, their fall risk, they're at an increased risk for bleeding because their liver's not functioning well too. There's a lot of things you have to consider for these patients. So keep those things in mind.
Yeah, that is good with the bleeding because platelet production, coagulation is controlled by the liver.
For sure.
Often have not great blood pressure, so bleeding out and losing volume with poor blood pressures also would not be one of the best things. So
right. So when in doubt, if you're not sure if it's a stroke or it's a possibility of like an encephalopathy exacerbation or something like that, I think it is easy for us to say err on the side of caution. If you're seeing something that looks like it might be a stroke, go ahead and page it out. Call the code stroke, because like I've said already, we would much prefer we go through the motions and rule it out than for it to get missed and fall through the cracks. So yeah, trust your assessment skills. Use those assessment skills, and then we can use our diagnostics to confirm or rule out your suspicions. So, okay. I mean, we take care of a lot of stroke patients. We take care of a lot of liver failure patients at our hospital. So we see a lot of both, and I think that's why we kind of get excited about this. These are both some of our specialties. And the other thing I want to talk about is kind of the human side of things. So like we want to make sure we are talking to our patients, educating our patients. We want to make sure we're talking to our family. I mean, I feel like when we do a code stroke, when we respond to a code stroke as a rapid response nurse, we're coming in very quickly. We're trying to get the patient moved. I try while I'm doing those things. I don't typically stop and tell family what I'm doing because, like we said, the time is so important. I mean, it is an emergency, a true emergency, but I try, and I'm sure this is not difficult for people to believe that I like to talk to people, but I do try to talk to the family about what they're seeing. I try to talk to the patient about what we're seeing and what we're trying to accomplish and why as best I can, because it can be a very emotional situation. I had a patient not too long ago. She had a history of strokes, and it was happening again. I mean, it was a true stroke. The symptoms were very similar, and it was an emotional experience for her because she knew she'd already had one. She was scared of having another, and it was happening regardless, no matter, I mean, she was doing all things right. She was taking her anticoagulants. She was very compliant, and yet it was still happening again. And so because it was so emotional, I did take a little extra time with her just to talk to her. Say this is what I'm seeing versus what I'm not seeing. When we rule out a brain bleed, I mean, I think it's important to say, hey, we don't see a brain bleed, which in a lot of cases is that's a devastating diagnosis in a lot of cases. So, hey, at least it's not that. And these are fast-paced situations, but these are still humans. So try your best to make those connections with people. So anyway, we do have a tip for new grads on this episode. So when you're facing altered mental status, you're really going to assess for a stroke first, okay? We're going to rule out a stroke first. That's your, if it's something else, that's your most acute situation. That's your emergency. And then if it's something else,
ask those questions.
Right.
Tips for new grads. Ask those orientation questions.
Definitely.
Don't assume.
Don't be afraid to ask for help.
Don't wake people up in the middle of the night.
Yes.
Make sure you're doing those assessments.
Yeah, for sure.
Because I put a blood pressure cuff on their arm because I didn't want to wake up. They said they weren't getting any sleep.
No,
but I didn't.
Unfortunately, the hospital is not a place
to sleep. They didn't raise their arm, so, and now, you're doing med surg report the next morning and they have unilateral weakness. You don't have a time for that.
Mm-hmm.
It's midnight.
I haven't talked to this. They haven't raised that arm in 8 hours. We hate those situations. I mean, I don't know those things don't happen.
It's so horrible.
But yeah, I mean, we never want to hear that. Well, I mean, I've been in here, but I didn't really talk to them. They were asleep. You don't want to hear those stories.
I always tell the patient, better to see me than not see me.
Yeah. Well,
I just gotta laugh.
Listen,
they're like, oh my gosh, he's back again.
If I'm a patient and Luke walks in my room, I'll probably walk on water to get out of there. No, I'm just kidding. He's a great nurse. I have to say that. So, okay. So I think we've gone over some great stuff to get with the guideline stuff. We've talked about the timeliness of everything. We've tried to hit as much as we can. I mean, this is not in depth, y'all. This is not in depth. Like this is us skimming over the top. I mean, you could really get into this deep.
Just like to motivate and say, like, one of our goals is, for people to get certified, seek out, like, advanced education. Ask your managers, ask your leaders, like, if you don't have, like, the NIH stroke certification or skill, like, if you don't have the ability to
it's a great application.
Ask for that module, that class, whatever it looks like.
That teaches you a lot about, I mean, those are really good points to incorporate into your neuro assessment, your day-to-day neuro assessment. Even if you don't do all of them, those are really good things to know and to understand what we're trying to look at in a stroke. I think it's excellent.
Yeah, I'm not sure every facility makes like every single person get
maybe not
stroke, certified or what, but definitely a good thing to ask for.
Definitely. And I recently, everybody here recently, we made the transition to Tenectaplace, or the T in case, as a facility. So we all went through a new training, and that really excited me because I was learning about a new drug. Have seen it before, but it wasn't very often. So, if you're a nerd like me or like Luke, yeah, he's definitely a nerd. But so if you're a nerd like us, like look at those two things and compare and contrast. I mean, I think I'm really excited about the lower margin for error with Tenectaplace, because it's a push dose versus a infusion. And so there's a lot less math to do, which is awesome too. So but anyways, these are things to look into, and that's we're kind of wrapping it up for this episode. So I do have to do my merch store plug. Don't forget to check us out, codebrewpodcast.myshopify.com, for some swag. We would love to see you out and about wearing some Code Brew swag. So and that would definitely help us out to keep things rolling. And as always, stay caffeinated, stay curious, y'all, and we'll see you next time on Code Brew.
Bye, everybody.